Assalamualaikum doctors. In this video I am discussing hypoglycemia history. So hypoglycemia history, it's okay, but it's a recall history. The features are, we understand that the child may be sleepiness, sweating, pallor, lack of coordination, irritable, hunger. So in exam normally it comes like a 2-year-old child with fainting attack. So suddenly a 2 years old child fainting attack. First, we chief complaint analysis. So OCD onset when started, how long, condition suffering, anything make it better, anything make it worse. Then before, what happens, what the child was before doing, during, what happened after. This is very important in any fainting attack. Then was it the first time to occur or recurrent? If recurrent, when was the first attack? What did you do when it occurred? Is it preceded by any fever or illness? Fasting overnight or infrequent feeding? This is very important. So before, during, after, was it the first time to occur or recurrent? If recurrent, what was the first attack? What did you do when it occurred and preceded by any fever or illness, fasting overnight or infrequent feeding? The nutritional history will take brought earlier. Tell me more about his feeding. Is he breastfed or formula fed? What type of formula? How are you feeding him? Who prepares the bottle? How many times? How much is he taking every time? Did you start weaning? Are you giving supplementation? So child feeding history is very important. Then general weight loss, change in appetite, daily activities and sleep. Any chronic condition, unusual facial features like large tongue and midline defect. Okay. The systemic review one by one. GIT, increased tummy size, hepatomegaly, tummy pain, loose poo, throwing up, oral soreness, lips is cracked, anal soreness and yellow eye. Endocrine, thyroid, hot intolerance, diabetes mellitus. Did you measure the blood glucose before? CNS about the feeds, loss of consciousness, unusual movements, sudden change in mood, unusual crying, morning vomiting, deviation of the face, eyes is red eye, cloudiness. Ears is large and creased, concern about vision, hearing or speech. The CVS about the racing of the heartbeats, fainting episodes, sweating during feeding. Hematology, pallor, bleeding, bruising and recurrent bugs. Urinary about the pee color, amount, painful peeing, recurrent bugs, frothy urine, urine dipstick, genitalia, private part, appearance and blood pressure measured. Then about the chest, rapid breathing, coughs and cold, runny nose, nasal discharge, chest pain, noisy breathing and recurrent chest bugs. MSK about the skin spots or pigmentation, swollen neck glands, lumps, bone pain, painful joints, bluish discoloration of the gums or nail, changes in hair and nails. Then about the past history 5T IOA, previous hospital admissions, team and trauma. Parental history will take like that: jelly skin in pregnancy, liver, birth weight, newborn heel blood spot test, any abnormality in newborn examinations, neonatal hypoglycemia. Neonatal hypoglycemia is very important asking because Beckwith-Whiteman syndrome is associated with neonatal hypoglycemia. Then prolonged jaundice and NICU admission. Development, gross motor, fine motor, social, speech and growth chart. Vaccination up to date and extra shots. Allergy to certain foods or drugs. Family consanguinity, family history of similar condition or any inherited disease. Previous sudden infant death. Are you living together? Do you have other siblings? Possible child access to medicine or alcohol, oral hypoglycemia agents, alcohol, aspirin, beta blockers and insulin. Then social, financial, home, psychological and impact. So this is the hypoglycemia history we can take how. Then the differential diagnosis of hypoglycemia: inadequate glucose intake or production or excess glucose consumptions. So the most common cause of hypoglycemia is ketotic hypoglycemia during periods of fasting and illness. So fasting, the child is not eating long time maybe, but endocrine and metabolic causes should be excluded first. So ketotic hypoglycemia is due to decreased glucose, undetectable insulin, increased non-stratified fatty acid, increased beta hydroxybutyrate. During a period of fasting or intercurrent illness, malnutrition, malabsorption, and sepsis, there is growth hormone deficiency, cortisol deficiency, and glycogen storage disease causes ketotic hypoglycemia too. So ketotic hypoglycemia because of long fasting, malnutrition, malabsorption, sepsis, due to growth hormone deficiency, cortical deficiency, glycogen storage disorder. Metabolic causes of hypoglycemia are glycogen storage disease, like commonly type 1 glucose 6-phosphate deficiency, and galactosemia, hereditary fructose intolerance, fatty acid oxidation defect, commonly MCAD, defect in amino acid and organic acid metabolism. Endocrine causes are hyperinsulinism, decreased glucose, increased insulin, decreased non-esterified fatty acid, decreased beta-hydroxybutyrate. So congenital or genetic defect in genes that regulate the insulin secretions. Transient is infant of a diabetic mother, maternal beta blockers, hypothermia, IUGR, and blood asphyxia. Exogenous is accidental injection, non-accidental, that is Munchausen by proxy, neoplastic, are insulin-producing tumors. Adrenal insufficiency are primary Addison disease, congenital adrenal hyperplasia. Secondary are ACTH deficiency or part of panhypopituitarism, trauma, tumor, and infections, growth hormone deficiency, and hypothyroidism. Syndromic causes of hypoglycemia are Beckwith-Whiteman syndrome, that is hyperinsulinism, septoptic dysplasia, that is panhypopituitarism. Hepatic are hepatitis, cirrhosis, and Ray's syndrome. Drugs and toxins are aspirin, alcohol, insulin, oral hypoglycemics, valproate, and beta blocker. So this is the DD of hypoglycemia you keep. Specially, I tell you ketotic hypoglycemia, remember. And the level in children is 2.6 millimole or 4 millimole per liter if diabetic. That is 2 years age old child I am telling. Thank you.